Eric, you want to give people a couple more minutes or?
Go ahead and get started. Yeah.
All right. Good evening, everyone, and welcome to the Forrester Lee Honorary Lecture. What I'm going to say is I'm essentially a mouthpiece for everyone because Woody's a legend here. So everyone who enters medicine brings with them a personal vision of what it means to be a doctor. For some, it's the pursuit of procedural mastery. For others, it's a deep dive into pathology, radiology, or the scientific complexities of disease. But for a rare and remarkable few, medicine is first and foremost a humanistic calling. For them, being a doctor is not just about diagnosing and treating illness. It is about truly knowing patients as people, listening with presence and empathy, and approaching each encounter with humility, committing to lifelong learning and devoting oneself to a life of service. Dr. Forrester Lee is the embodiment of that ideal. And this is why it's such a profound honor to have a lecture named in his honor. It is a celebration of a physician, educator, and leader whose influence has shaped Yale cardiology, Yale heart failure, and the School of Medicine in lasting and transformative ways. When I first joined the Yale heart failure faculty about a decade back, it became clear almost immediately that Dr. Lee was Yale heart failure. He set the standard, the gold standard for excellence in every dimension, a clinician who cared with uncommon grace and wisdom, a teacher who shaped generations of physicians, and a leader who broke barriers and built bridges with quiet strength and unwavering moral clarity. His commitment to mentorship and the human side of medicine has left an indelible mark on this institution, and all of us are privileged to learn from him. The Forrester Lee Woody Lee Lecture is a tribute to that legacy. It reminds us that the highest form of medical excellence is not measured only by knowledge or innovation, but by character, compassion, and a steadfast commitment to those who we serve. Please join me in welcoming Dr. Lee as we welcome Dr. Michelle Kittleson, who will deliver this year's lecture in the spirit of his extraordinary example. Thank you.
I have the great pleasure of introducing our speaker tonight, Dr. Michelle Kittleson. Dr. Kittleson serves as the Director of Postgraduate Education in Heart Failure and Transplantation. She's the Director of Heart Failure Research and is a Professor of Medicine at the Smith Heart Center at Cedars-Sinai. She graduated from Staples High School in Westport, so she's a local product, before going on to Harvard College and then coming back to Yale, where she earned her MD degree here at the Yale School of Medicine. She completed her internship and residency in internal medicine at Brigham and Women's, and then pursued fellowship training at Johns Hopkins. While at Hopkins, she also earned a PhD in clinical investigation from the Johns Hopkins Bloomberg School of Public Health. Dr. Kittleson has served on the board of directors of the Heart Failure Society of America, previously held the position of interim editor-in-chief of the Journal of Heart and Lung Transplantation, and works as an associate editor for the Journal of the American College of Cardiology. She is the author of over 60 peer-reviewed publications in the field of heart failure and transplantation, as well as review articles, editorials, and book chapters. She participates in educational efforts on a national scale, serving as chair of the writing group for the 2020 AHA Scientific Statement on Cardiac Amyloidosis, and as a member of the writing committees for the ACCHA 2020 Hypertrophic Cardiomyopathy Guidelines and 2021 Heart Failure Guidelines. Dr. Kittleson has appeared as a guest on numerous podcasts and was the host of Medscape in Discussion, Heart Failure. She has published medical narrative essays in the New England Journal of Medicine, Annals of Internal Medicine, JAMA Cardiology, along with poems in JAMA and the Annals of Internal Medicine. And finally, she has published her first book known as Mastering the Art of Patient Care. And for those that know hashtag Kittleson Rules, if you don't know, she'll let you know what that's all about. Michelle, thank you so much.
Wow, I'm so delighted to be here. I have the most amazing memories of being a medical student at Yale, class of '99. And Dr. Lee might not remember me because you only remember the best and the worst students, but I remember him, and it was a delight to learn from him. And also give a shout out to my parents who are listening on Zoom right now. So hi, Mom and Dad. I hope you enjoy the lecture. They retired cardiologist and pathologist affiliated with Bridgeport Hospital. Okay, so let's dive in. And the first is how to figure out how to work this. Okay, perfect. So I have no relationships to disclose. No one pays me to say anything. And everything I'm going to tell you, or much of what I'm going to tell you, comes from these two seminal documents, the 2022 Heart Failure Guidelines, as well as this 2023 Expert Consensus Decision Pathway document published on heart failure with preserved DF. And I was, humble brag, honored to be the chair of that document. So everything is more interesting when we talk about a patient. So we're going to begin with a case. A 72-year-old woman presents with a 2-week history of shortness of breath. She has hypertension, paroxysmal atrial fibrillation, and osteoarthritis. Her medications include rivaroxaban, chlorothalidone, amlodipine, and ibuprofen as needed for knee pain. On exam, BMI 31, heart rate 68, blood pressure 142/88, JVP 10, lungs clear, S4 gallop, and 2+ edema. Her echo shows mild increased LV wall thickness, EF 60%, mild aortic stenosis, and mild pulmonary hypertension. So when this patient walks into your clinic, dyspnea, edema, and preserved ejection fraction, you have to figure out what's going on. And what I found the most challenging thing in medical school was that you spend all this time learning about diseases, but patients don't have diseases, patients have symptoms, and you have to learn how to walk backward the art of differential diagnosis. It was actually one of my medical school mentors, Dr. Quagliarello, who first taught me that when you think about the dreaded differential diagnosis, you should organize your etiology by pathophysiology and anatomy. So if we take dyspnea, we say, well, it could be the heart's fault, it could be the lungs' fault, or it could come from someplace else. And if it's the heart's fault, it might be the muscle, the vessels, the valves, the pericardium, or the electrical system. And if it's the lungs' fault, it could be the airways, the parenchyma, the pleura, or the vasculature, or it could be other places like decreased oxygen carrying capacity of the blood or neuromuscular disease, deconditioning, or anxiety. But this is cardiology grand round, so we're going to focus, of course, on the cardiac causes. And you can do the same exercise with edema. The edema might be because you have increased capillary hydrostatic pressure or decreased capillary oncotic pressure. And if it's decreased capillary hydrostatic pressure, it could be the heart's fault, the muscle, the valves, or the pericardium. It could be the liver, the kidney, or something that is anatomical like venous insufficiency, pregnancy. If it's decreased capillary oncotic pressure, it might be not enough protein intake, not enough protein production, or losing protein through the gut or the kidney. And I love this exercise, particularly for trainees, because it can take what can seem like an overwhelming list and systematically funnel it down so you don't miss anything. So when your patient walks into clinic, you run through this in your head, and then you ask yourself, what's the most likely diagnosis? Cardiac amyloidosis, heart failure with preserved ejection fraction, hypertrophic cardiomyopathy, aortic stenosis, pulmonary arterial hypertension. And you would say to yourself, well, this is a talk on HFpEF, so I clearly know the answer to that question. However, let's think about the other things on our differential. Cardiac amyloidosis is always possible, so more on that in a few slides. HCM doesn't make sense. By very definition, it's unexplained increase in LV wall thickness. Hers is explained by having hypertension. 72 is a little old. Aortic stenosis, come on, her valve wasn't that bad on exam or echo, and she's not the right demographic for group 1 pH, and her PA pressures weren't that high. So when you think about dyspnea, edema, preserved ejection fraction, you can go back to the universal definition of heart failure and say, does the patient have symptoms and or signs of heart failure caused by a structural or functional abnormality corroborated by at least one Elevated natriuretic peptides are objective evidence of congestion. Now, when you think about HFpEF in particular, remember that the ejection fraction will be preserved. And remember that the natriuretic peptides don't help you as much because they are often lower for a given elevation in left ventricular end diastolic pressure, also confounded by obesity, which lowers natriuretic peptide levels. I don't need to tell you guys the symptoms and signs of HFpEF, but I love these old Framingham criteria because they really divide it into things that are more specific and things that are more sensitive. Our patient has enough of them to say, yes, she has symptoms and signs of heart failure. And then you think about the typical demographics and associated conditions, the company that HFpEF keeps. You think about how it's common in older age, women, hypertension, AFib, diabetes, coronary disease, obesity, kidney dysfunction. Now the new hot term, which we all love, is CKM, cardio, kidney, metabolic disease, which really encompasses all the comorbidities of HFpEF. And even though the echocardiogram might have a preserved ejection fraction, it doesn't mean the echo is normal. There can be increased LV wall thickness, increased atrial size due to the chronic elevation of end diastolic pressure. Diastolic dysfunction, of course, is neither necessary nor specific for the diagnosis of HFpEF, common just with aging, but can be useful if observed, as well as elevated estimated right ventricular systolic pressure, again, transmission of that increased left ventricular pressures. And our patient had a number of those. What about these other things? What about maximum oxygen consumption, peak VO2 on cardiopulmonary exercise testing? What about right heart catheterization? They're really more useful in a research perspective. I typically do not employ these in clinical practice, but rather will treat someone empirically who seems to smell like HFpEF. But right heart cath changes with exercise can be useful, though unclear how this fits into our clinical algorithm. So I've told you a lot about symptoms and signs, demographics, associated conditions, suggestive findings on echo, which have actually been very beautifully encapsulated in the H2FPEF score. So the H2FPEF score takes 6 readily clinically accessible variables and translates them into a probability of HFpEF. So if we do it for this patient, we give her an elevated BMI, 2 or more antihypertensives, AFib, elevated right ventricular systolic pressure, older, score of 8, 95% probability of HFpEF. It's easy, right? HFpEF is so easy. But unfortunately, patients don't read textbooks. So let's tweak the patient a little bit and see what happens. It's still a 72-year-old woman, but now she's a more indolent history, 2 months. And it's not just shortness of breath, there's some fatigue. Doesn't have hypertension, but does its paroxysmal AFib, bilateral carpal tunnel, spinal stenosis, some neuropathy. Her medications include the rivaroxaban, metoprolol, gabapentin, no more antihypertensives. She's not obese on exam. Her blood pressure is not high. Her JVP is a bit worse, and her echo looks exactly the same. So if this patient walked into your office and I said, what's the most likely diagnosis? Because you were at an amazing center for cardiac amyloidosis, you'd say, duh, of course that is the diagnosis. However, if you did the your trusty H2FPEF score, which should never let you down, and you get a score of 5, which is an 85% probability of HFpEF, how do you reconcile this? You reconcile this by realizing that HFpEF is a diagnosis of exclusion, which are the hardest diagnoses to make. So whenever someone has dyspnea, edema, and a preserved ejection fraction, and you think it's the heart's fault, you have to ask yourself, is there a restrictive cardiomyopathy, hypertrophic cardiomyopathy, valvular disease, right heart failure, obstructive lesions, pericardial disease, high output heart failure? Now, the good news is an echo will rule out a lot of this stuff and the history will never let you down. But it's important to do this mental exercise because you never want to deprive your patient of disease-directed therapy that can improve their outcomes. And what are some of the clues that it's not garden variety HFpEF? Well, every disease has a rhythm and a trajectory. And the longer you live in medicine, the more you internalize those rhythms and trajectories. And the rhythm and trajectory of HFpEF is a period of relative quiescence, punctuated by discrete exacerbations with identifiable triggers like took an NSAID, got volume overloaded. as opposed to amyloidosis, which has much more of a slowly progressive and indolent course. If a patient's a lot younger, you think, could this be HFpEF? Probably not. If they don't have those typical comorbidities like the obesity, the hypertension, the diabetes, and think about that QRS voltage and how it fits. Because if the walls are thick, and the QRS doesn't match, that's a red flag. One of my pet peeves in life, I have many, if those of you who follow me on Twitter know all about my pet peeves. One of them is when you read an echocardiogram report and it says moderate left ventricular hypertrophy. How do you know it's left ventricular? How do you know it's hypertrophy of the LV muscle? How do you know it's not infiltration? You already anchored away from half the causes of increased LV wall thickness. So always think to yourself, the walls are thick. Do I know why? And does the EKG fit? So this is a nice figure from our expert consensus decision pathway document. Dyspnea, edema, preserved ejection fraction. First question, is it the heart's fault? Maybe the congestion is actually from the kidneys, the liver, or chronic venous insufficiency. That's an important exercise because it's very hard to unring the bell of misinformation. And if the patient thinks they have heart failure, it's very hard to help them unthink that. But if you think it is the heart's fault, then you have to ask yourself, is there an underlying cause that I should investigate for disease-directed therapy, like an infiltrative cardiomyopathy? And if you've satisfied yourself there is not, then you will turn your attention to the comorbidities associated with HFpEF. So I'm never one to advocate for more testing, but I'll always advocate for more thinking to lead to the figuring out what tests your patients need. So a few quick words on cardiac amyloidosis, which help you with your differential. As you all know, it's a condition where there's a protein that infiltrates the myocardium that results in a restrictive cardiomyopathy. The two most common sources will be the immunoglobulin light chains, AL, on the spectrum of a plasma cell dyscrasia between MGUS and multiple myeloma. The other source is the TTR, transthyretin protein, which in turn comes from one of two places, a variant in the gene or the wild type form. In the olden days, we used to call that senile cardiac amyloidosis, but we don't because that hurts people's feelings. The better term is wild type TTR cardiac amyloidosis. Thank you for laughing, whoever that was. And then we have to remember that the protein just doesn't go into the heart. It goes other places as well, which is often the clue to the diagnosis. There can be neuropathy. There could be nephropathy unique to AL, gastrointestinal involvement, and orthopedic issues. So we think about heart failure symptoms at the tip of the iceberg. We remember the other stuff, the other cardiac issues like AFib, AV block pacemaker. We remember the ENCASE series of patients with HFpEF or severe AS, when tested, about 13 to 16% have underlying or concomitant cardiac amyloidosis. We think about the discordant LV voltage, sensory neuropathy, autonomic dysfunction, like the patient has a little bit of hypertension and you give them a little bit of a vasodilating antihypertensive and all of a sudden they faint. That's a sign that it could be autonomic dysfunction, the carpal tunnel, the spinal stenosis. So then when this patient walks into your clinic, it jumps out at you. Of course, there's something funny going on here. Carpal tunnel, spinal stenosis, peripheral neuropathy, no good comorbidities. Why is her LV thick? She doesn't have hypertension. And the seemingly disparate findings lead to a satisfying, unifying diagnosis because so much of medicine is pattern recognition and you won't miss this pattern. And I do all of that exercise because I think one of the cardinal most important things we can do with HFpEF is make sure we get the diagnosis right. And that's the exercise there. But now let's go back to HFpEF and let's turn our attention to treatments. So Dr. Lee told me before I started this talk that he was excited to hear it because there's not really much we can do for HFpEF. And he's right. And if I was giving this talk a few years ago, it would be a very sad and desperate affair. But fortunately, we have better things now to talk about. So if I asked you which of the following treatments is recommended for HFpEF, you'd say, really none of them. I mean, maybe furosemide, but everything else doesn't seem to work. And whereas you'd say, well, for HFrEF, there's potentially a role for all of these. And one of the basic challenges of HFpEF management is our total inability to understand the unifying pathophysiology. So if we think about HFrEF, It's a triumph of translational medicine, where our understanding of these tiny little molecules has translated into medications that help our patients feel better, stay out of the hospital, live longer. But if we think about the pathophysiology of HFpEF, it's not so clean, is it? When I think about the pathophysiology of HFpEF, I like to liken it to the parable of the blind men and the elephant. So you might know this parable. 6 blind men encounter an elephant in a field, and they all come at the elephant from different angles. And whether or not they encounter his tusk, ear, trunk, side, tail, or leg, they try to convince each other that an elephant is a spear, fan, wall, rope, tree, or snake, meaning they only see a tiny part, they don't understand the whole. And that's really where our understanding of HFpEF pathophysiology is, in the sense that we know there's diastolic dysfunction and myocardial stiffness. We know there's people with systolic dysfunction and chronotropic incompetence. There's reduced arterial compliance, decreased skeletal muscle oxygen extraction, decreased flow-mediated vasodilation, RV dysfunction, pulmonary hypertension. We know these phenotypes exist, but it doesn't quite make sense how we incorporate them into a unified, pathophysiologically directed treatment plan. But there is cause for optimism, because in recent years, we've had a lot of advances. And when I used to give this talk, I just list therapies that don't work. But now I can say we can divide our therapies into the bad, the meh, and the wow. So these are the ones that don't work. Isosorbide dinitrate hydralazine, irbesartan, perindopril, statins, digoxin, nebivolol, ivabradine, isosorbide mononitrate, sildenafil, serelaxin, and the interatrial shunt devices. May they rest in peace. That being said, there are therapies that do work. And when we think about those, I am going to highlight the ones here. And we're going to begin, in fact, with one of my favorite stories, which is the story of spironolactone. So, spironolactone, mineralocorticoid antagonist, studied in the TopCat trial, which came out over a decade ago. 3,400 patients, symptomatic HFpEF, spironolactone versus placebo, did not meet the primary endpoint of a reduction in the composite of death and heart failure hospitalization, but did meet the secondary endpoint of a reduction in heart failure hospitalization. And as expected, those patients on spironolactone had a little bit of a bump in their potassium and creatinine. And this would have been the end of it. But everyone was sort of sad about this finding because it was just supposed to work. So those geniuses who run the clinical trials did a deep dive into the data and said, this is an international trial, but there's something funny going on here. Half the patients came from the Americas and half the patients came from Russia and Georgia. And something was very strange about the 49% of patients enrolled in Russia and Georgia. Their event rates were mysteriously low. So about 20% of patients in the Americas are hospitalized after 6 years. Only like 3% of patients in Russia and Georgia, mysteriously healthy HFpEF population. Also strange that patients in Russia and Georgia who ostensibly received spironolactone never bumped their potassium and creatinine, which speaks to some potentially nefarious trial going on. I love how the authors of this subgroup analysis put it in their circ paper. It is puzzling why these findings happen, puzzling indeed, but it makes you wonder if half the population never had HFpEF and half the population never got the drug, so the trial as a whole was a wash. But sadly, wishing something does not make it so, and that is why spironolactone received a Class 2B weak indication in the 2022 heart failure guidelines because TopCat did not meet its primary endpoint. And this is all anyone said. And if I were giving this talk about 2 years ago, I would say to you, but I believe in spironolactone and I give it to my patients because I really think subgroup analyses are hypothesis generating, but this one is really believable. And I would have ended there and gone on to the next medication. But now I can tell you about finerenone. So finerenone is another mineralocorticoid antagonist, non-steroidal, in the Fine Arts trial, where there were 6,000 patients with symptomatic HFpEF. It met its primary endpoint of a reduction in cardiovascular death and heart failure hospitalization driven by worsening heart failure. So spironolactone, finerenone, are they different? Do we care? Well, it's a non-steroidal MRA with, as the authors say, a physiochemical properties distinct from those of spironolactone, balanced distribution between heart and kidneys, short half-life, active metabolites. So really what you all want to know Is this a triumph of finerenone, or is this a vindication of spironolactone? And when I don't know the answer to a question, I go to Twitter and I ask my closest friends. And so I did. And I went to Twitter and I said, fine arts, top cat, which one will you use? And 523 people voted. And look at that. It's a split. I don't think many people know exactly what to do. So here's my take on it. My take on it is that perfect is the enemy of good. So if my patient can afford finerenone and money is limitless, then take finerenone, go by the clinical trial. But if they can't, and I'd rather spend the money on some of the other medications we're going to talk about, then spironolactone is just fine. So that takes us through the mineralocorticoid antagonists, bit of a controversial tale. Now let's go to a straightforward tale. One of the SGLT2 inhibitors, these magical and mysterious agents that burst onto the scene. They work for diabetes, they work for HFrEF, they work for CKD, and they work for HFpEF. Very exciting, actually, that Emperor preserved 6,000 patients, symptomatic HFpEF, empagliflozin versus placebo, reduction in the primary endpoint of cardiovascular death and heart failure hospitalization, followed the next year by DELIVER, same population, same results with dapagliflozin. So extremely exciting, two congruent trials that show these agents work in HFpEF. We should put them in the water of HFpEF patients. So then you'd say to yourself, but wait a minute, I've read the 2022 heart failure guidelines, and it only gave it a class 2A, not a class 1. Well, that's more just timing. Only one trial had come out at the time the guidelines were published. The second trial came out after. But I think we can all say with confidence that this is absolutely indicated. Whatever SGLT2 inhibitor you like is indicated for patients with HFpEF. Let's talk about some more muddy areas, the ARNI. The ARNI. So ARNIs were amazing, right? In 2014, Paradigm HF, the ARNI knocked the reigning ACE inhibitor off its throne as the first line agent of RAS inhibition for HFrEF. Why not try it in HFpEF? So Paragon didn't meet its primary endpoint of a reduction in cardiovascular death and heart failure hospitalization. It did not meet its secondary endpoint of a reduction in heart failure hospitalization. And internet pundits at the time said, but if there'd only been 7 more events in the placebo arm, it would have met its secondary endpoint. But wishing does not make it so. And the subgroup analysis, yes, showed a signal towards benefit in women and those with lower EFs. But based on the fact that it did not meet its primary endpoint, it has a 2B indication. So where do I see it? I don't see it as requisite therapy, like the SGLT2 inhibitor and the MRA. But you know what? If you need to lower someone's blood pressure, and you often do in HFpEF, and they happen to be a woman, and they can afford it, go ahead, add it on. I think that's a very useful role. Similarly, we have the angiotensin receptor blockers. Charm Preserve was pretty awesome, came out over 2 decades ago. Subsequent studies did not show the same benefit from ARB, so they get a similarly weak indication. But again, you think of them in your toolkit for managing the hypertension these patients are going to have anyway as one of their comorbidities. And if they can't afford the ARNI, it's a very reasonable alternative to get a 2-for-1, control blood pressure and affect comorbidities. And speaking of comorbidities, now you're thinking to yourself, what about the obesity? I love this figure on the left. This is such a beautifully elegant trial. It is 100 patients with HFpEF, average age 67, average BMI 39, who were randomized to calorie restriction, take out 400 calories a day, or supervised exercise training 3 days a week, cardiac rehab, and said, how do you feel and how fast can you move? And lo and behold, that if you calorie restrict and exercise train, you will have additive benefits on your exercise capacity as measured by peak VO2. And if you calorie restrict, you'll improve quality of life. This benefit of exercise has been shown in the forest plots on the right in multiple trials. If you needed more evidence, it is here. There's many studies to show us that exercise and weight loss helps patients with HFpEF feel better. And if I was giving this talk 2 years ago, I'd say, but it's really hard to affect effective weight loss. and I'd end it there. But now I have more to say because we have the magical and mysterious incretin-based therapies, those GLP-1, GIP receptor agonists that don't just treat diabetes, but also treat the stomach, treat the brain to have effective weight loss. So the first signal of benefit of these agents in HFpEF came from the STEP HFpEF trial. Patients with HFpEF and a BMI median 37, given semaglutide weekly for 52 weeks, they felt better, they walked farther, they had good weight loss, about 10-12% weight loss after a year. And you might say, well, great, these agents are effective at helping people lose weight, but anyway they lost weight, they'd feel better, right? And they actually published simultaneously with this New England Journal paper, one in Nature Medicine, showing the magnitude of benefit based on the magnitude of weight loss. And it kind of makes sense. More weight loss, more benefit. So are these just super effective ways to help people lose weight? Or are there additional benefits to these agents for heart failure itself? So this was STEP HFpEF. That second question, is this just weight loss or something more, was attempted to be answered by the SUMMIT trial, which is a dual GLP-1 GIP receptor agonist tirzepatide. Again, enrolled patients with HFpEF, elevated BMI, and it met its primary endpoint of a reduction in cardiovascular death, worsening heart failure as expected, good weight loss, improvement in quality of life. But why do I sound not so excited? Well, I sound not so excited because we have to remember that there were relatively few events. As the trial was initially put together, I don't think anyone was actually shooting for clinical outcome benefit. It's a pretty small trial, only 731 patients. But on the heels of all the benefits from the other trials, like the SELECT trial, the authors pivoted to say, let's try to look for these hard endpoints. And they found them, but they're small numbers and it's short follow-up. So I think we have tempered enthusiasm. But that being said, for your patient, while HFpEF alone might not be the sole indication to give a GLP-1 GIP receptor agonist, chances are they'll meet one of the other approved indications, like the coronary artery disease, the elevated BMI with comorbidities, the obstructive sleep apnea for which therapy can be justified. So that takes us through therapies, but we can't forget about the many comorbidities that contribute to the morbidity and mortality of HFpEF, the hypertension, the diabetes, the obesity that then drives the sleep apnea, CKD, CAD, and AFib. And again, I've talked with so many of you today in these wonderful meetings we had before the grand rounds about silos and how we try to get away from our silos. And really, HFpEF is a great test case for that because of the cardiac, kidney, metabolic contributions. And so we have to pay attention to all of it if we're going to take good care of our patients. So if we're thinking about AFib, remember that you will do rate versus rhythm guided by symptoms, and you'll avoid aggressive rate control due to this low fixed stroke volume of HFpEF with its restrictive physiology, and you'll anticoagulate your patients. You'll remember that when it comes to hypertension, low-hanging fruit of the ARNI, ARB, or MRA, you'll treat coronary disease, which is very prevalent in patients with HFpEF. And when it comes to diabetes, it's a brave new world where SGLT2 and GLP-1 receptor agonists have become first-line therapy for patients with diabetes and coronary atherosclerotic cardiovascular disease. And you'll avoid the thiazolidinediones, allogliptin, saxagliptin, which increase the risk of heart failure. We will not be scared of CKD, but now be very excited that we have pillars of medications that prevent the progression, like the RAS inhibitors, SGLT2 inhibitors, and know that these ARNIs and SGLT2s are safe up to pretty low GFRs. We'll remember to screen for sleep apnea, daytime somnolence, daytime headaches, and snoring, because treating it will improve patients' quality of life, and it's a brave new world of obesity. But it's tough because nobody can know everything, and it's getting harder and harder to know everything. And the bottom line really is it takes a village. I also have 3 children, but I haven't found a village to help me with them yet. So if anyone knows about that, feel free to tell me. But when it comes to the village of patient care, we really do have extraordinary teams and members, especially at an amazing place like Yale, where you have the resources and the initiative and the aptitude to create these teams, where you have the nursing, the home care, the physicians, the geriatrics, the comorbidity specialists, palliative, pharmacy, social work, advanced practice professionals. So really, you don't have to know all the right answers. You just know where to find them, and sometimes they're with your team. So I'm going to end with just a really fascinating evolution of what the guidelines have told us about treating HFpEF. So if we take this snippet from the 2022 heart failure guidelines, what do we see? We see diuretics are the only strongly recommended therapy because they're a necessary evil. SGLT2s, okay, yellow, 2A, weak, and then everything else is, gosh, it probably doesn't work. When we go to the 2023 expert consensus decision pathway document that we published, we raised SGLT2 inhibitors to a position of prominence based on the data. And what's extraordinary to me, it's like only 2 years later, and this figure is completely out of date. So if anyone has any contacts with the ACC, tell them we need to rewrite this because it's not accurate anymore, because we have so many incredible therapies that we can now use to help our patients. So if I had to redo that figure now, I would say SGLT2 inhibitors and MRAs are standard of care for all our patients with HFpEF. You want to use a finerenone versus spironolactone. Again, perfect is the enemy of good. Diuretics remain a necessary evil. If you have an elevated BMI, think about your GLP-1 GIP receptor agonists. If you have someone with hypertension and you need to use something else, reach for the ARNI-R because there is data for those. So in summary, HFpEF is a diagnosis of exclusion. Your echo helps. Your history is also important, so don't miss amyloidosis. Implement promising therapies, SGLT2, MRA, and incretin-based therapies, and then use your village to manage your comorbidities. Thanks so much for your attention. Mhm. Mhm. Give that to you. Thank you.
Any questions? Michelle, that was fantastic. Maybe I'll start, getting Judy going. So, as we develop technologies to define, try to estimate, filling pressures, we built these models around that histology in the program. Can you tell us how you handle that information, whether you look for, do you modify your treatment strategies based on information you may find on that kind of standard testing?
Yeah. It's really fascinating to me. And I grew up in the era of looking at the JVP, and honestly, I still look at the JVP. I think there are other ways to do it now. There's the wireless implantable pulmonary artery sensors. There are these point of care ultrasounds, but I think you have to think about the physiology of HFpEF versus HFrEF. I think HFrEF is pretty straightforward. Dry them out. You'll get their Frank Starling curve will look better. You afterload reduce them. Their cardiac output will go up, and everyone will be happy. You can take someone with HFrEF, and it's pretty straightforward if they're not super shocky, take them to warm and dry, which is the Platonic ideal. But can you do that with HFpEF? Can you do that with restrictive physiology? So remember, HFpEF or amyloidosis, they function the same way. You have a fixed stroke volume, so you don't respond well to afterload reduction. You don't enjoy afterload reduction because if you vasodilate, you just get tachycardic because you can't increase your stroke volume in response to afterload reduction. You also are very dependent on your blood pressure and on your heart rate to control your cardiac output, so you don't like beta blockade. And also you're very stiff, so small changes in volume lead to big changes in pressure. You have a very narrow window of euvolemia, so it's very easy to be orthostatic or congested, but how do you go in the middle? All of that is a long way of saying, when I have a patient with HFpEF, or particularly one with amyloidosis, the way I manage volume is I tell the patient, The diuretic is not a set it and forget it, not for you. You have to figure out where your sweet spot is. And your sweet spot might be, I feel a little lightheaded and I have no swelling, or I'm not lightheaded, but I do have a little edema. And every day your diuretic is a game time decision to make that reality happen. So I find an obsessive management of filling pressures is really key in HFrEF, but it just doesn't work so well when you have that restrictive pattern.
Thanks. Any other questions? Anyone from the audience on Zoom? We have over 60 people at least at one point on Zoom. Woody, you're gonna.
Yeah, having been in not in the clinic for about 5 years, I think I'd have a hard time coming back to practice today. It's gotten a lot more
No way.
complicated.
You would master it. You would be showing us all up within half a clinic.
Yeah. I think you've opened the door here for discussion about where AI figures into this whole scheme in the future. I suspect it's going to be very, very important, not only for diagnosis, but for treatment and for, because in the end, you know, the cardiovascular system does not like stress. So anything you can do to reduce that stress, and there are probably a lot of ways we're not even thinking about now that perhaps AI will give us, oh, why don't you consider this kind of approach to it? But
Yeah.
but I'm just curious whether AI has invaded your life in any way that was
Yes.
significant.
You know, when you say that our systems don't like stress, I think the physician system doesn't like stress either. So if we have an AI way to make our lives easier, we're going to be very happy. Okay, so you know what? I think AI could be useful in a number of levels, and I totally pie in the sky saying, can it, because often these patients with dyspnea, edema, and a preserved ejection fraction don't even come to the cardiologist, right? You're managed by your internist, and you're old, and you're deconditioned, and you're overweight, and you never get to the point where a cardiologist is going to manage you. So can AI pluck people from the EMR who may benefit from either cardiovascular evaluation or amyloid testing, or disease-directed, guideline-directed medical therapy? Because the other thing I feel for internists or even general cardiologists or specialized cardiologists, you can't know everything. So if a reliable implementation algorithm was available for you when the patient meets a diagnosis, we'd all get a lot better at knowing what we're supposed to do. You know, I just read the 2025 ACS guidelines from ACC-AHA, and I'm like, I can't keep all this stuff straight. I need an AI algorithm to tell me when am I supposed to get prasugrel and when am I not. So I think to that point, that's how AI can be most useful, I sense. Hi.
Erica Spatz.
So
Good
nice
to
to
see
see
you in
you.
person. I get to see Michelle every week on our Jack call. And thank you, because it's a terrific talk. And you always teach us so much on both our calls as well as today. My question is around, you know, the algorithm at the end that you presented and like where to start. And, you know, when we think about like HFpEF related to obesity or, you know, obesity and HFpEF and are thinking about visceral adiposity and pericardiac fat and inflammation of perivascular inflammation. I mean, do you see a world where we're starting with GLP-1s as like at the top of the food chain and then seeing what else is needed after we potentially address, reverse that pathology related to the visceral adipose depots of the heart?
I love that question. And, you know, I love it because it really gets at the wonder of clinical trials and the problems of clinical trials, right? Because clinical trials can't tell you everything. So this supposition, even when we think about quadruple therapy for HFrEF, is just keep adding on. And the problem with these advances is, are the trials done on the background of the standard therapy, or are they done instead of standard therapy? So to your point, we now know with MRAs and SGLT2 inhibitors that in patients with HFpEF, they reduce this primary composite endpoint of death and heart failure hospitalization driven by a reduction in heart failure hospitalization. That's a hugely lofty goal. We don't have that strength of evidence yet with the GLP-1 GIP receptor agonists. So I'm remaining cautiously optimistic that a larger trial with longer follow-up will show that. And while they won't stratify randomization based on MRA and SGLT2, hopefully there'll be some proportion of patients on it, hopefully a large proportion, so we can say, in the setting of perfect background therapy, it is still effective. But you raised such a fascinating point, will these agents through obesity alone reverse the HFpEF phenotype altogether, rendering the other medications moot? But I think HFpEF is more than obesity. It is a syndrome of aging. There are other cardiac, like CAD, kidney metabolic findings that may, I don't know if the mediated risk is truly all through obesity or not. So I'd say for now, SGLT2 MRA for everyone. As we have more data, perhaps it'll be now one of these incretin-based therapies for everyone. And then some brilliant clinical trialist is going to do the study where they also look at, when I give these agents, am I curing the HFpEF phenotype, much like we can cure HFrEF in 30% of non-ischemics with quadruple therapy.
Can I ask you a question? Can you hear me?
That was a terrific talk. Welcome back, Michelle. So I wanted to ask an endothelial-centric question. So you had very briefly mentioned that there's endothelial dysfunction in HFpEF. So I wondered if you thought that that was related to the often underlying metabolic abnormalities, or whether there's something about HFpEF pathophysiology that also leads to microvascular dysfunction, and also why nitrates were on your bad list, because those are NO donors, as you know, and if there's endothelial dysfunction, you would like to have more nitric oxide available. So.
Yeah, I mean, I think that was the supposition behind those nitrate trials, but the pathophysiology of HFpEF, to me, there was significant exercise intolerance when nitrates were given to patients with HFpEF. That was really the classic New England Journal trial. And what I think that speaks to a number of things. Yes, there's evidence of abnormal flow-mediated vasodilation or other endothelial dysfunction, but there's also a vast phenotype. And I think the problem is when you test everybody with nitrates, maybe only a subset who actually were identified with that phenotype would get better, but you're diluting them with the trial as a whole. Like HFrEF trials are easy. Throw spaghetti at a wall, it'll stick if you have a low EF. HFpEF is much more complicated, I think, because of the phenotyping. And the problem with that argument, which I still believe in, is even if you phenotype well, like if you look at the left atrial hypertension population in which the interatrial shunt devices were tested, they didn't work, though ostensibly those patients were very well phenotyped, which speaks to other issues. I think HFpEF becomes a larger problem, and that is the best explanation for why no benefit, even though ostensibly it should have worked in some of the patients. I think the other important point, I like to think of HFpEF as not a heart condition, but a body condition. It's like the rheumatology of cardiology, right? And I guess with lupus, depending on which organ is affected, you might treat someone differently. I don't think we have that clear enough. And the reason why the things like SGLT2 and GLP-1s work is because we don't exactly know what they do. And because they do so many things we don't know about is why they seem to work for a condition we don't understand.
Can I ask a question?
Any questions from the audience online?
Yes.
Going once or going twice. Arya, you want to speak, but we don't hear you, so you might unmute yourself.
Oh, I'm actually unmuted. I don't know why the voice doesn't come in. Can you hear me now? I'm
This was
unmuted.
fantastic. We look forward to a few of us celebrating dinner with Woody tonight in both of your honors, and really welcome back to Yale, and thanks for all you do.
Great, thank you so much.
I guess couldn't hear me.
Nutraceuticals, like you're California, so you've had a lot of people, wellness freaks are coming in with like a bunch of stuff. What do you say to avoid this?
I typically tell them we have no idea what these are doing. On one hand, maybe they can't hurt, but I'd say take them at your own risk. I never say don't take them, who listens to me anyway.
Well, they're gonna take it anyway.
Exactly, so he's
But I
my
would say like,
conscience is clear.
I love it when they complain and they can't afford their medicine, but they're spending like $1,000 on the side.
Or they come in with their $3,000 purse, and I'm like, there's something that's not quite right here. Exactly. Well, thank you. Yes, go to your meeting.
And then I'll see you in your week.
Yes, I'll see you there. Thank you. Oh, thank you.
What do you think about CRP? Because both the summit trial.
I did. I think that's a mechanistic explanation for why things work, how that becomes actionable. I don't know.
You know, I agree with you that is probably the spectrum.
Yeah.
The question, when you get older, it's hard to